This is Randy Schell, and I'm making a video cast on the topics respiratory anatomy, physiology, and thoracic anesthesia. It's part 2 of a 3-part series in our keyword review at the University of Kentucky Department of Anesthesiology. As a reminder, keywords are the topics published by the American Board of Anesthesia, and we take those topics over the last decade or so and put them together into this review. These are the keywords published by the American Board of Anesthesia in 2017 on the topic respiratory and thoracic anesthesia. But let's move right into our next topic in this series, and that is acute hypercarbia and the effects of acute hypercarbia. When the PaCO2 rises to greater than 45 millimeters of mercury, we say that's hypercarbia, and it can be secondary to inadequate ventilation, where CNS depression could be the cause from opioid administration, or neuromuscular depression from residual neuromuscular blockade, rebreathing when the CO2 absorber is used up in the anesthesia machine, or the inspiratory and/or expiratory valves are not functioning properly. Acute hypercarbia can also be due to increased production, for example, CO2 being insufflated through a laparoscope and CO2 being absorbed into the bloodstream. TPN, administration of lots of carbohydrate calories, and we know that the respiratory quotient of carbohydrates is 1. More CO2 is produced per calorie than is calories from lipids, for example. Bicarbonate administration, giving an amp or two of bicarbonate, and CO2 will be produced from that, and then tidal CO2 will rise acutely. And when you release a tourniquet from an extremity after a period of time, watch the end tidal CO2 rise. Because metabolism occurs, CO2 is produced, the tourniquet's released, and it's released into the bloodstream, and acute hypercarbia ensues. The signs of acute hypercarbia include some perioperative signs like flushed skin, a rise in norepinephrine levels with associated hypertension, tachycardia, ventricular premature beats from the stress response of the hypercarbia. Mentation can be depressed as CO2 continues to rise, and even coma occur. In the recovery room, it's not uncommon to be called to see a patient with depressed mentation who is receiving supplemental oxygen, so their saturation is reading often in the high 90s. And you visit the patient and say, I'll bet you they have acute hypercarbia from opiate administration. You draw blood gas and their CO2 is 80 or 90 or even more sometimes. So acute hypercarbia can result in tachycardia, hypertension, ventricular premature beats in these patients. Some organ effects in the brain. Increased CO2 results in increased cerebral blood flow. If the CO2 is very high, narcosis can occur, and large increases in CO2 can depress the electroencephalogram. It takes really large changes, high PaCO2, for MAC to be altered. In fact, between about 20 to 100 millimeters of mercury of PaCO2, there's no change in MAC. What about the heart? CO2 is a direct depressant of the cardiovascular system, but in an active sympathetic nervous system, when the CO2 comes in, it activates it, and catecholamines go up. So the indirect effect is a rise in catecholamines, sympathetic stimulation, and a rise in blood pressure, heart rate, and cardiac output until the CO2 rises so high, and then there's a depression of cardiac output, blood pressure, and heart rate. The respiratory system responds to a rise in CO2 with increased minute ventilation, again until the CO2 rises very high, and then further increases actually depress respirations. The pulmonary vascular resistance goes up as CO2 rises, and there is a right shift of the oxyhemoglobin dissociation curve as CO2 goes up, and acidosis ensues. Metabolically, hypercarbia results in a stress response with increased norepinephrine. The respiratory acidosis that ensues with hypercarbia increases potassium. And one way to remember this is that alkalosis, which has LO in the name, is associated with a low potassium, while acidosis is associated with increased potassium. Some causes of low end tidal CO2. You should look at the waveform as well as the absolute value when there's a low end tidal CO2. A sudden drop to 0 or near 0, then absence of the waveform, you should think of disconnection from the circuit, possibly cardiac arrest. An abrupt decrease can occur from embolism, for example, a large thrombus or fat embolus or air embolus or amniotic embolus. Severe hypoperfusion of the lungs with increased dead space can result in a low end tidal CO2, secondary to low cardiac output or shock. And the classic example of this would be a hip surgery where the hip prosthesis is being hammered in, a fat embolism occurs, and suddenly the end tidal CO2 goes from 35 down to 15. Or the trauma patient who's bleeding out, and when they open the abdomen, there's so much blood that comes out, the cardiac output becomes very low, and the end tidal CO2 goes from 30 again down to the low teens or even lower. A gradual decrease in end tidal CO2 could be due to a decrease in metabolic rate, like hypothermia, or it can be due to increased minute ventilation. Here's a question for you. What is the result of a bilateral carotid endarterectomy on ventilatory response to hypercarbia and hypoxia? You should remember that the carotid body responds to PaO2, so that if a bilateral carotid endarterectomy was performed, the response to hypoxia would be greatly diminished, such that if a patient became hypoxic, they would not increase their minute ventilation like a person who did not have that bilateral carotid endarterectomy. Let's move on to another keyword, which is pulmonary physiology and shunt. Shunt is perfusion of an alveolar unit without ventilation. An example of that would be a mainstem intubation. Let's say you have a patient who you put in a Trendelenburg head-down position, and maybe they're having abdominal laparoscopic procedure, and maybe they're a little bit overweight, and the abdominal contents push up on the diaphragm. The tube migrates down into the right mainstem, your peak airway pressures go up, and your saturation drops from the shunt. The AA gradient, alveolar to arterial gradient, goes up, and initially there is a decreased end tidal CO2 as the full minute ventilation goes to one lung. The hypoxic pulmonary vasoconstriction in the non-ventilated lung kicks in and increases pulmonary vascular resistance and should shunt blood more to the lung that is being ventilated. Now, the normal shunt from bronchial, pleural, and Thebesian veins, the veins in the heart, is about 3% of the cardiac output. And when a patient has a lot of pathophysiologic shunt going on, you can increase your FiO2 from room air 21% to 30% to 40% to 80% to 100%. And increasing FiO2 does not improve oxygenation much when there's a large interpulmonary or intracardiac shunt. Now, shunt can be calculated using a shunt equation, QS over QT, using content of the arterial and the venous system. And for those who are interested, the equation is shown below. But let's talk about dead space next. We talked about shunt first, which was perfusion without ventilation. Now, if you have ventilation going to an area of the lung without blood going by, that is dead space. And the classic example of that is zone 1 of the lung, shown in the graphic at the top right. In a standing patient, it is at the apices of the lung, where P big A pressure, alveolar pressure, exceeds P little a, arterial pressure, and exceeds P little v, which is venous pressure, such that the alveolar pressure is higher than the arterial pressure, so there's little blood flow up there, but there's continued ventilation. That's dead space. So zone 1 of the lung is dead space. Normal anatomic dead space of an adult patient is about 2 mils per kilogram, or for a 70 kilogram patient, that's about 150 mils just to get air down the plumbing to the alveolar exchange gas exchanging units, the terminal bronchioles or beyond. VD over VT stands for dead space over tidal volume. And classically, if you think of dead space being that 150 mils and a tidal volume of a normal patient being about 450 mils, the ratio 150 over 450 is about a third, or 0.3. The Bohr equation can be used to estimate the VD over VT, where you use arterial CO2 minus expired CO2 over arterial CO2. That's the Bohr equation. That's a way to calculate VD over VT. Now, some things that change dead space to tidal volume ratio. If you do a tracheostomy in a patient, you have bypassed the oral pharynx, and you actually decrease anatomic dead space. A reason for doing a tracheostomy might be problems weaning someone from a ventilator. And if you reduce the dead space, it may make it easier. Intubation with spontaneous ventilation, if you put a tube down someone and bypass the oropharynx with this small diameter tube, you actually decrease dead space. However, if they are intubated and you start mechanically ventilating them, the dead space goes up. And if you think about that for a moment, mechanical ventilation is positive pressure ventilation. That means P big A becomes greater, alveolar pressures, and so zone 1 of the lung goes up. So tubing someone reduces the dead space, but if they're tubed and not breathing spontaneously but with mechanical ventilation, VD over VT rises from 0.3 up to about 0.5. And when you put a face mask on someone, you're introducing even more dead space. In the ICU, if you do a VD over VT calculation and it comes up to greater than 0.6, you say, we're not going to wean that patient because they have so much dead space. We need to work on their lung disease. There's some factors that can increase VD over VD, and airway pressures is one of those. If they're very high, P big A will be high and zone 1 will be increased. Increased age has more dead space to tidal volume ratio. Things like a pulmonary embolus, and we already talked about mechanical ventilation with positive pressure raising P big A in zone 1. Where's the dead space though in our circle system? It's distal to the Y piece. It is not in the corrugated tubing, assuming that you have a normal inspiratory and expiratory valve only allowing gas to go in one direction in your circle system. So if you introduce a humid event, that is dead space. But if you put two corrugated tubings together and pull them apart, if you have a normally functioning inspiratory and expiratory valve, that does not introduce dead space into the system. Let's talk about compliance of the lung next. That's the next key word. Compliance is a change in volume over a change in pressure, delta V over delta P. And we say that if something can change its volume a lot, like a balloon, without a little bit of change in pressure inside, that's very compliant. As opposed to if you get very little volume change with a lot of pressure, that's not very compliant. When we look at the compliance of the thoracic system, it's made up of the thoracic cage plus the lung combined. And each of those compliances can be defined separately, where the thoracic cage compliance is about 200 mils per centimeter of water. The lung is about 200 mils per centimeter of water. But when we add compliances, it's done in parallel rather than series. So 1 over the thoracic cage plus 1 over the lung compliance, with the total compliance of the system being about 100 mils per centimeter of water. Now there's several types of compliance, dynamic and static being the ones we'll talk about next. And if you look at the graphic on the far right here of pressure versus time, you can see that airway pressure has a peak and a plateau. Now dynamic compliance is defined as a tidal volume over the peak pressure, minus PEEP if you have any applied to the system, while static compliance is tidal volume divided by the plateau pressure. Now let's look at these a little bit more in depth. Dynamic compliance is the tidal volume divided by the peak pressure. That reflects resistance to gas flow in the ventilator tubing, the endotracheal tube, the airways. I like to think of it as getting air all the way down to the alveolar units. If you have bronchospasm, if you have obstruction of the endotracheal tube, dynamic compliance and your peak airway pressure goes up and your dynamic compliance goes down. Now static compliance is a tidal volume divided by the plateau pressure. Plateau pressure is the airway pressure required to hold the lungs and chest wall at end inspiration when gas flow is absent. So I like to think of that as, what does it take to hold the alveoli open? And a stiff lung, a lung with pneumonia, would have a low static compliance. Let's move on now to acute respiratory failure. Acute respiratory failure can be defined by hypoxemia when the PaO2 is less than 60 on an FiO2 of 60% or more with a large AA gradient. We say that's hypoxemia. It can be hypoventilation when the CO2 rises greater than 50 millimeters of mercury, or the VD over VT is greater than 0.6. And it can be due to abnormal respiratory mechanics, where you just are breathing very rapidly or have a low vital capacity, less than 15 mils per kilogram, or you can't generate a negative inspiratory force of more negative than minus 20. In fact, at the end of an anesthetic sometimes, in the olden days, we used to sometimes close off flow, take the bag off, put your hand over and occlude where the bag was, and as the patient took a breath in, you watched, and if it was greater than minus 20, you said, they're strong, they can be extubated, at least as one criteria for extubation. The next topic is interpretation of arterial blood gases as a key word. One of the key words was related to when you send off a blood gas, what is measured and what is actually calculated from that specimen. Now, what is measured is pH, the PaO2, and the PaCO2, but from that is calculated bicarbonate and base excess. What is the effect of temperature on the arterial blood gas? Hypothermia, when the blood gas patient is cold, the kinetic energy of the oxygen molecules and the CO2 molecules go down. So they don't bounce around as much and create as high a partial pressure. So the PaO2 goes down, the PaCO2 goes down with hypothermia. And if the PaCO2 goes down, that's a form of respiratory alkalosis. So if a patient is pulled, let's say, from a motor vehicle accident where their temperature is 30 degrees centigrade, normally you could draw blood gas from them. It's at 30 degrees. You send it to a blood gas machine. The blood gas machine actually warms it up to 37 degrees and spits out a number. Let's say a PaO2 of 200 and a PCO2 of 40. But that is at 37 degrees. And you know that if it was corrected for temperature, the PaO2 would be lower than 200 and the PaCO2 would be lower than 40. So temperature effect on arterial blood gases. A simplified way to interpret arterial blood gas is to look first at the pH and to say, is it acidemic, less than 7.35, alkalemic, greater than 7.45, and then look at the PaCO2 and ask the question, does the change in PaCO2 from 40 account for the change in pH from 7.4 normal pH? And if it's a pure respiratory problem, a 10 millimeter change in PaCO2 should change the pH approximately 0.08 units. And if the answer is it does change it that much, for example, CO2 rises, it would be a respiratory acidosis, and that would be a simple respiratory disturbance. If this 10 millimeter PaCO2 change and a change in 0.08 pH units isn't true, we say that's a mixed acid-base problem, and we begin to look at other things like bicarbonate and do other calculations to determine what is going on. Now, one of the key words from several years ago was the etiology of respiratory alkalosis. Anxiety, a patient breathing rapidly, stroke, drug use like aspirin and doxapram, which is a respiratory stimulant. When you go up to high altitude in response to the low barometric pressure and low PaO2 and low PaO2, little PaO2, your carotid body senses that and you hyperventilate at high altitude, at least acutely. Lung disease with low oxygen, you breathe fast, fever, pregnancy, all examples where you can have a respiratory alkalosis. Next topic is anion gap from your arterial blood gas. And simplistically, you should think of this as the positively charged cations, that is, minus the anions, the negatively charged ones. So sodium and potassium are the main cations, chloride and bicarbonate, main anions. And so in general, we take potassium out of that because it doesn't contribute much, and we say sodium minus chloride plus bicarbonate is approximately 8 to 16 milliequivalents per liter, and that's the anion gap. Positives minus the negatives, 8 to 16. Now, we have unmeasured anions, and one of those is albumin. If you have a very low albumin level, it can cause a low anion gap, and lactic acid could build up in a hypoalbumic patient, and you don't recognize the acidosis, specifically the anion gap, because the albumin is masking it. So you have to correct for hypoalbuminemia. Some causes of metabolic acidosis with a high anion gap would be lactate, diabetic ketoacidosis with ketones, alcohol, methanol, uremia, aspirin, cyanide. And a normal anion gap would be something like diarrhea and renal tubular acidosis, among others. Strong ion difference is, again, the difference between the positively charged molecules and the negatively charged molecules, like sodium, potassium, calcium, and magnesium are positively charged, and then chloride and lactate are the main negatively charged ones. But in the graphic, you can see that there's a lot of unmeasured anions, like phosphate that's not figured into this, albumin, and others. So there's a strong ion difference between the positives and the negatives of about 40, assuming that you have normal albumin levels. And that strong ion difference can be used in our blood gas analysis, and we're going to talk about that next. Well, what can increase the difference between the positively charged and the negatively charged and increase that strong ion difference? Well, dehydration is one, or contraction alkalosis, where the potassium, that is the sodium, goes up with contraction alkalosis. When dehydration, you've lost water. And if sodium goes way up, the positive charges go up, and the difference between positives and negatives gets wider and wider. That's an increased strong ion difference. Another example would be loss of anions, like chloride loss from aggressive NG suctioning. Now what happens is you have a lot of water in your body, and as the ion difference occurs, water can dissociate to hydrogen ion and make up some of these differences. Or in the case of decreased strong ion difference, normal saline administration, lots of it, when you pour in liters of normal saline, where normal saline is 154 milliequivalents per liter of sodium and 154 milliequivalents per liter of chloride, that's a lot of chloride being poured into a person. And the chloride is negatively charged, right? So if you have more negatives going into a patient who's been given 5, 6, 7, 8 liters of normal saline, the difference between the positively charged and the negatively charged become less, okay? Because you're given lots of the negatively charged chloride. And so strong ion difference becomes decreased. And what has to happen? Your body says, we need more positive ions because we got all these negatively charged ones around, and water dissociates to the hydrogen ion, which is acid, and you get this hyperchloremic metabolic acidosis, which is associated with large volume normal saline resuscitation, a classic keyword topic. Other things that can decrease the strong ion difference are things like unmeasured anions, things like lactate building up, or ketoacids in the case of diabetic ketoacidosis. Let's talk about PEEP next and some of the effects of PEEP. PEEP is positive end expiratory pressure, and it's often used in patients who are hypoxemic with lung disease in an attempt to re-expand collapsed alveoli. Now, what happens to lung water when you add PEEP? It redistributes from the alveolus into the interstitium. Does it decrease lung water? No, it just redistributes it out of the alveolus into the interstitium. It can reduce VQ mismatch, it can recruit alveoli, and it definitely increases functional residual capacity, which is the volume of gas that's left in the lung at the end of a unforced exhalation. So if you keep PEEP on, let's say 5 of PEEP at the end of a normal tidal volume, that lung is going to be distended more and have more FRC, higher FRC. We often will add PEEP in patients who are hypoxemic on FiO2s greater than 60%, and even CPAP, if you give it, let's say, to a patient in the recovery room, 5, 8, 10 centimeters of CPAP, that's going to increase the FRC, decreases the work of breathing, and decreases airway obstruction in patients with obstructive sleep apnea, the reason why they use CPAP at night. So some complications of PEEP next. One, if intrathoracic pressure rises from PEEP, venous return and cardiac output can go down. Lots of PEEP, 10, 15, 20, we start worrying about barotrauma and pneumothorax. And if you don't give time for a patient to exhale, they can stack breaths and get air trapping, or what's called auto PEEP. And an example would be the top right, where expiration is occurring, but before it reaches baseline, the next breath kicks in and you have air trapping. What happens then is there's air trapped in the lung, the next breath kicks in, more air trapped in the lung, the next breath kicks in, and next thing you know, your intrathoracic pressure is so high that venous return goes down, and if you have an A-line in, you can watch your arterial blood pressure just drop off to much and nothing. One of the examples of not giving enough time for exhalation would be a lung transplant patient where oftentimes we need IE ratios of 1 to 4 or more, or they will stack breaths. We don't use PEEP to reduce lung water per se in patients with pulmonary edema, because PEEP actually redistributes the water from the alveolus to the interstitium and can actually increase the water content of the lungs, possibly because it distends the alveoli, impeding the lymphatics that drain the lungs. Also, another thing associated with PEEP is that it can increase dead space, because if you raise P big A, alveolar pressure, by increasing PEEP, more zone 1 can occur. And if hyperinflation of normal alveoli occurs predominantly rather than recruitment of previous collapsed alveoli, this may not be a beneficial effect. So PEEP decreases venous return, can cause barotrauma, can cause auto PEEP if you don't give time for exhalation, and actually increases lung water and potentially increases dead space. Complications of PEEP. The next key word is lung protection, ventilation, atelectasis, and recruitment. Lung protective ventilation, normally we're thinking of patients with adult respiratory distress syndrome, and some of the recommendations to keep the tidal volume low, 6 milligrams per kilogram, and keep our airway plateau pressures less than 30 centimeters of water. This is in an attempt to reduce lung injury from inflating lungs with high pressures and high volumes, causing pressure trauma and volume trauma. Also, in these patients with ARDS who are going to be intubated for an extended period of time, special tubes can be used with subglottic secretion drainage in an attempt to decrease the chance of ventilatory-associated pneumonia, or VAP. When you put a patient in the ICU in a 30 degrees head-up position, one of the reasons we do that is try to reduce the chance of ventilator-associated pneumonia. And if they have a tube that has a drainage just above the cuff, and so you're sucking out the stuff that's going down there, and so it doesn't go around as much the cuff and go into the lung, potentially reducing VAP. How do we prevent atelectasis in patients? If you have your normal muscle tone without neuromuscular blockade, it seems to maintain muscle tone and have less atelectasis if you're not paralyzing them. PEEP can prevent atelectasis, but if you turn off the PEEP after it's been on, the lung rapidly collapses after you discontinue it. Recruitment maneuvers, if you close your APL valve and raise the pressure up to, let's say, 40 centimeters of water and hold it there for 7 to 8 seconds or so, the classic lung recruitment strategy, you can pop open atelectatic lung, but it takes pretty high pressures and for an extended period of time. And you should be watching your blood pressure during this time, because as the intrathoracic pressure rises, venous return can go down and blood pressure can drop dramatically. If someone is administered a high FiO2, that can result in absorption atelectasis, and with gas reabsorption can occur collapse of alveolar units. So avoiding high FiO2 is a way to prevent atelectasis. We mentioned reopening collapsed airways. A lung recruitment maneuver requires high peak airway pressures, 40 centimeters of water, so maintained for an extended period of time. And then if you put them on PEEP afterwards, you can keep those lungs open. Let's look next at some pulmonary lung volumes. And if you look at the graphic, you can see VT stands for tidal volume. And here's a normal tidal volume going along, and then a patient takes a large inspiration, which is inspiratory reserve volume, and then exhales totally, and the difference between those two is vital capacity. The gas that's trapped in the lung you cannot get out is called residual volume, and the gas that's in the lung at the end of an unforced exhalation, a normal tidal volume, you blow air out and stop, that's FRC. FRC is very important. That is the gas that's in your lung after you exhale, and that's like when you induce a patient and they stop breathing, and you've pre-oxygenated them with 100% oxygen, the FRC is full of oxygen. And the FRC normally is about 35 mils per kilogram, or approximately 2.5 liters. So if you had 2.5 liters of FRC filled with oxygen in a patient who's now apneic, you've just put him to sleep with anesthetic agents, then you have 2.5 liters of oxygen, and if their metabolic rate is 1, that's 250 mils a minute, you theoretically have 2.5 liters at 250 mils a minute you're using. That's 10 minutes before you theoretically use up all the oxygen. So you can see why you can go for an extended period of time of apnea, maintaining oxygenation if the FRC is filled with oxygen. You cannot measure FRC with normal spirometry because you cannot measure residual volume, which is the air that's trapped in the lung, and FRC is made up of expiratory reserve volume plus residual volume. Now, what are some things that decrease FRC? Well, obesity and pregnancy, things that push up on the abdomen and push up on the bases of the lung. Things that increase FRC, well, the asthmatic emphysematous patient has a large lung with a lot of trapped air, so big residual volume. And old age, elderly patients lose the elasticity of the lung, and they have a big lung with large amount of trapped air, residual volume, and a high FRC. Let's look at pulmonary function tests and use them to determine whether a patient has obstructive versus restrictive lung disease. Let's look at the graphic on the far right first, which shows on the y-axis airflow in liters per second, and on the x-axis lung volume in liters. If you look at the normal patient in blue, you can see that there's pretty high airflow rates, and you can see that the residual volume is approximately 2.5 liters here, while the restricted lung patient has low flow rates and is a very small lung volume compared to the normal patient. The obstructed patient also has low flow rates, but they have a huge lung with a lot of trapped air and large residual volume. So when you have a patient take a breath in and exhale during spirometry, you can measure FEV1, which is forced expiratory volume in 1 second, FVC, which is forced vital capacity. If you just give them time, how much air can they get out? And if you look at the ratio between FEV1 and FVC, it should be greater than 80%, meaning that in 1 second you can get out more than 80% of your whole vital capacity in normal patients. And in restricted patients, that ratio is maintained greater than 80%, as opposed to an obstructed patient where the ratio of FEV1 to FVC is less than 80%. It takes them a long time to get the gas out, but if you give them time, they can get a lot of it out, but with a lot of trapped gas, residual volume. So comparing the two in the graphic on the left, forced vital capacity, the restricted patient is very low. The FEV1 is decreased in both, but greatly decreased in the obstructed patient. The FEF 25-75, which is the midpoint of expiration, is what we call the effort-independent portion of the spirometric exam. That tells you a lot, classically anyway, we think of the small airways in an obstructed emphysematous patient greatly decreased. But it's usually the ratio of the FEV1 to FVC that we use to determine is this obstructed versus restricted. If you look at FRC, residual volume, and total lung capacity, that green arrows at the bottom remind you that the obstructed patient has a huge FRC because of lots of trapped gas, residual volume, and big, large lungs because of trapped gas in them. As opposed to the restricted patient, the red arrows going down, very small lungs, small FRC, small residual volume, but the ratio, FEV1 to FVC, is greater than 80%. Let's look at obstructive lung disease now in more detail. The graphic on the right shows the obstructed lung, which is big, huge, with trapped residual volume, increased FRC, and a ratio of residual volume to total lung capacity high, meaning that there's a lot of trapped gas. The work of breathing is increased in the obstructed lungs. The lung volumes, as we said, are increased. The FEV1 is greatly decreased, such that the ratio FEV1 to FVC is less than that 80%. And that's classically the asthmatic, emphysematous, chronic bronchitic patient who you need to give adequate expiratory time to get the gas out, i.e. ratios 1 to 3, 1 to 4, or more sometimes. Or if the next breath kicks in before they're fully exhaled, you can have auto-PEEP or intrinsic PEEP, rising pressure in the chest, trapped gas, decreased venous return, and hypotension can result. Now the restricted lung, the graphic on the right, shows that small lung with low vital capacity, residual volume, FRC, tidal volumes, total lung capacities, all small. The lung compliance as well as the diffusion capacity, which we're going to talk a little bit more later on, is decreased. So these are often stiff lungs, not very compliant, that are very small. The FEV1 and FVC are both decreased, but if you look at the ratio, it is greater than 80%. And causes of this are things like pulmonary edema and pulmonary fibrosis that are intrinsic to the lung. It can be a chest wall problem like neuromuscular diseases and flail chest and spinal cord injury. It can be a decreased compliance of the chest wall, such as, or the chest itself, with obesity, pleural effusions, pregnancy, mediastinal masses, and spine issues like kyphoscoliosis. Let's look at flow volume loops next and look at the graphic at the top right first. This graphic is showing a inspiration underneath at the bottom of the inspiratory flow and expiratory flow curve here, and at the top expiration. So if we look at the far right, we have the beginning of inspiration, take a big deep breath in, and then full expiration with the triangular, it looks relatively triangular as opposed to the inspiration looking like a hemisphere. That's the classic shape of a flow volume loop. The end of full expiration would be the gas trapped in your lung or residual volume. Now there's some classic patterns that are shown at the bottom, and let's look at the fixed defect first. A classic example of that would be a goiter or tracheal web or a stricture after someone who's been intubated for a long time and gets tracheal stenosis. In that case, air coming in, inspiration, is truncated. Air getting out doesn't have as high flow rates, and so both inspiration and expiration don't have the classic pattern of flow volume loop. They're truncated flows in both inspiration and expiration. Let's look at another example, which is the variable defect extrathoracic. If someone had a vocal cord palsy, as you exhale, the vocal cords are blown apart, okay, but and the flow volumes are normal, but as you take an inspiration, they are truncated because the vocal cords slam together and collapse on themselves, and that extrathoracic defect, the vocal cord palsy outside the thorax, results in an inspiratory flow problem. Now let's take another example. A bronchial tumor that's in the chest, interthoracic. It's called variable defect, and it's inside the chest, interthoracic. So that bronchial tumor is sitting there way out in a bronchus, and as you take an inspiration, it pulls the bronchus apart, and there's good flow rates. But as you expire, the bronchus collapses on itself, air doesn't go by, and the flow rates are greatly decreased. So this is an interthoracic lesion causing an expiratory flow problem. So in general, my mnemonic for you to help remember this is if it starts with an I, interthoracic, it's an expiratory flow problem. If it starts with an E, it's an extrathoracic lesion. It is an inspiratory problem. And that's one way to remember these flow volume loops. E goes with I goes with E. Let's look at DLCO next, or diffusion lung capacity for carbon monoxide. Now, when you do DLCO measurements, you're trying to determine how good can gases pass through the alveolar membrane. And things that can affect that are, for example, the area of alveoli in a lung. If you took out one whole lung, obviously you've dropped the area that gases can pass through. It could be thick, from pneumonia that would make gases not pass as easily through. So you're trying to determine, are there factors that affect diffusion of alveolar capillary membrane, in the case of the test, to carbon monoxide. Now the way the test simplistically is done is you have a patient breathe a known very small concentration of carbon monoxide, take a breath in, hold the breath, and during the breath hold for a certain period of time, the carbon monoxide in the alveolus rapidly passes through the capillary membrane into the blood, binds to hemoglobin, aggressively binds to hemoglobin, as you know, and carbon monoxide is carried away rapidly, creating a gradient for the carbon monoxide to continue from the alveolus into the blood, alveolus into the blood, and when the patient exhales, you measure the amount of carbon monoxide that is present. The less carbon monoxide that is present during exhalation means that you've picked up more. So things that decrease the DLCO, make carbon monoxide not pass through the alveolar membrane as much, is loss of lung volume or capillary bed perfusion. An example of this would be fibrosis of the alveolar tissue, pneumonectomy, taking out a whole lung, emphysema, where you have destruction of alveolar units, and something that you may not have thought of much is anemia. Because of the way the test is done, if you don't have much hemoglobin, it's not going to carry away the carbon monoxide, and a patient that's very anemic will have a low DLCO. Or if they have a very low cardiac output, not much blood going by the alveolar unit to pick up the carbon monoxide done during the test, it can decrease DLCO. But in general, we think of DLCO being a problem with loss of lung volume or capillary beds, such as an emphysema, pneumonectomy, or fibrosis of the lung. Things that increase the DLCO are more blood going by the alveolar unit, more hemoglobin going by the alveolar unit. So exercise, a big left to right shunt where blood is going from the left ventricle into the right ventricle, filling the lung with blood and picking up more of the carbon monoxide. Polycythemia, where you have so much hemoglobin, let's say a hemoglobin of 18 or 20 going by that alveolar unit, picks up a lot of carbon monoxide, and the DLCO will be increased. So DLCO can be affected by blood flow, hemoglobin, and lung pathology. Here's a question for you. Following preoxygenation and denitrogenation in a 20-year-old otherwise healthy male, the time to onset of oxygen desaturation after induction of general anesthesia and with apnea is closest to which of the following? And this question, you really have to think of, okay, how big's the FRC? It's full of oxygen. How long can they go? They can go 6 minutes or more. And we'll end with that. This is part 2 of the respiratory keyword topic review. This is part 2 of a 3-part series. This picture is from 2015 in Italy, the Dolomites, when I was bicycling there. A beautiful place to bicycle up these mountains and to see the Italian countryside. I hope you have a great day and keep studying.